afternoon to all. Today, I'm going to present comprehensive eye examination at Vision Centers. My name is Rajathi, and I'm working as a vision technician at Gandhigram Vision Center. So the aim is to ensure that people have access to eye care services that needs at every stage of life. This includes not only prevention and treatment services, but also rehabilitations. Aims to address the full spectrum of eye diseases. What is my role as a technician in Vision Center? Ensuring the diagnosis, accurate diagnosis, facilitate treatment for the patient who visit Vision Center and save their vision. Increasing the uptake of eye care services among the patients who are advised for treatment through proper counseling. We are also doing emergency management in Vision Centers. Injuries like trauma, foreign body or chemical injuries and conjunctivitis, ocular pains, chemical injuries, foreign bodies, we removing foreign bodies and we give the treatment for these kind of emergencies. If patient needs immediate care, they will be directly taken to the consultation room for the doctor consultation. Comprehensive eye examinations also done at Vision Center. The following tests are done in Vision Center. They are vision and refraction, history taking, anterior segment examination by torchlight and slit lamp also, posterior segment examinations, basic investigation, and also we doing special investigations also at Vision Center. First, visual acuity. Everybody knows visual acuity is measured by Snellen chart for adults and Shadian-Gardiner chart or picture chart are used for the young children. Normal visual acuity is 6 and most important test is pinhole test. This pinhole test can distinguish if the reduced vision is due to refractive error or other cause. So we have to remember the point. Always keep in our mind when doing visual acuity test. Check each eye separately and examine the eye which patient is complaining. For example, if patient says defective vision in left eye, we have to check the vision first at left eye. After that, we have to check the right eye. History taking. History taking is an important test because history taking is give the more details about the patient's eye conditions. We have to take his detailed history before starting the examinations. So we have to ask the patients following questions and we have to take the following histories too. First, ocular histories. This ocular history include any ocular trauma, injury, or any other ocular surgeries, or patient using any medications. This kind of information we have to gather from the patient. And also systemic history like diabetic, hypertensive, thyroid, etc. And surgical history, whether they undergone any surgeries. And also family history. If any other family members are using anti-glaucoma medicines, are having a defective vision at the evening time like retinitis pigmentosa. So we also ask this kind of details from the patient. If we are seeing the pediatric age group, we have also asked birth history too. Preterm, if patient admitted in NICU, oxygen supplementary is given or not. So these kind of information also we gather from the patient. In clinical examinations, we are doing anterior segment examination and posterior segment examinations. Anterior segment done by torchlight and slit lamp. Posterior segment examination done by direct ophthalmoscope. And after dilatation, 90 diopter lens or 78 diopter lens with the help of slit lamp. And also we are taking fundus photograph in fundus camera. Anterior segment examination we are seeing through torchlight, ocular adnexa. Then pupillar reaction. People is reacting is normal, brisk or slow. If having any relative apparent pupillary defects is there, apparent pupillary defect is there, APD. So we have to check these things with the help of torchlight. And extraocular movements also we have to check with the help of torchlight. And facial abnormalities like ptosis or any lag of thalamus or any other mouth deviations. These things are checked by torchlight. If we are not seeing these things by the help of torchlight, we are going to miss these findings. If we get the direct examination in slit lamp. So we have to check the facial abnormality with the help of torchlight. In slit lamp, we have a detailed examinations in corneal diseases like any other small foreign bodies is there, infiltrate is there, or corneal ulcer. These kind of things checked by slit lamp. And iris is anterior chamfer depth and status of lens, immature cataract or early cataract or mature cataract. These things are checked by slit lamp. What should not be missed doing anterior segment examinations? Any corneal infiltrate, we do not miss these things because small corneal infiltrate, if not treated properly, this leads to corneal ulcer, that leads to irreversible vision loss. And also we have to check shallow anterior chamfer. Anterior chamfer depth is normal or shallow, we have to check clearly. In this picture shows the shallow anterior chamfer, the first one. The down one is normal depth. If we are not checking the shallow AC, it leads to angle closure glaucoma. And also we have to check relative apparent pupillary defect is there or not, because RAPD is the important sign of optic nerve dysfunction. And operable cataract, immature cataract, grade of cataract, NS1 nuclear sclerosis levels we have to check. And extraocular muscles, any other nerve palsy is there or not, and facial abnormalities also we have to check. These things should not be missed. In posterior fundus, we have to check step by step. First, we assess the media. The media is clear or not. This media haziness due to any other cataracts or any other opacities like posterior capsular opacification or corneal opacities. So any medial opacity is there or not, we have to check first. Then we have to assess the disc. In this, we need to check shape, size, and any other cupping is there. We have to check. Then vessels. Vessels are normal size, normal width is there. So we have to check vessels and background retina. After that, we have to check the macula and foveal reflex. In optic disc changes, may be caused disc edema. This disc edema may be in papilledema, optic neuritis cases, anterior ischemic optic neuropathy cases. We have to see the changes of optic disc. And this pallor we have to see in optic atrophy conditions. And glaucomatous cupping is there. Also, we have to find out. In background retina, we have to check diabetic retinopathy. We also need to grade the diabetic retinopathy. That is mild, moderate, or severe. And macular pathologies also we have to diagnose. That's a CSR, central serous retinopathy, clinically significant macular edema, or significant macular edema is there or not, or central macular edema is there or not, we have to check it. These are the ways we are doing the posterior segment examinations. The first picture shows direct ophthalmoscope, and the second one is 90 dioptrical lens with the help of slit lamp. The third one is slit lamp mounted fundus camera, and the fourth one is handheld fundus camera. The image is taken from the camera, then we send through the images to the teleconsultation doctor. The doctor seeing the images, then doctor will give the advice. What not to be missed in the fundus examinations? Any other disc changes, glaucoma changes, and optic atrophy, diabetic retinopathy changes, and vascular occlusions also we should not miss. What should be done? This means if patients come our vision center with the complaining of redness, pain, photophobia, so we diagnose the condition is iritis. In iritis patient, we have to do intraocular pressure and dilate fundus examinations, because generally iritis patients, a doctor will advise the steroid drops. The nature of steroid drop is increasing IOP. So before starting steroid drops, we have to check intraocular pressure. Then episcleritis patients, we have to do dilate fundus examination also. When patients come with the complaints of headache, each headache patient should be done dilate fundus examinations. Or any other injuries or trauma patients come our vision centers, we are doing dilate fundus examinations and color vision and central fields also we are doing. This central fields done by confrontation method. Every post-op follow-up patients, we have to check intraocular pressure and dilate fundus examination because patient already using steroid drops. So the intraocular pressure level is normal or high, we have to check it out. So we have to do post-op follow-up patients, intraocular pressure, and then dilate fundus examinations. And other than that, all above 40 patients, we have to check intraocular pressure, BP, and blood sugar, and dilate fundus examination is mandatory. Exceptions are infective cases. Before dilatation, we have to check the anterior chamber depth. If patients have AC shallow, we do not dilate. If patients are AC IOL, anterior chamber IOL, do not dilate. If patients having high blood pressure, do not dilate. The basic investigations are intraocular pressure measurement, blood pressure measurement, blood sugar, and lacrimal duct examinations, muscle balance. This lacrimal duct and muscle balance for needed patients only. Special investigations also doing in vision centers. Those are visual fields by confrontation method, binocular single vision by Worth-Ford dot test, color vision by Ishihara chart in digital vision chart. Who needs these special investigations? Any patients come with injury or trauma, we have to do color vision and central fields. If patients having severe headache, we have to do color vision and central fields. And neuro disorders patients also, we have to check color vision and central fields. If patients saying defective field of vision or blurring visions in one side, we have to check central fields by confrontation method. Any patients complaining with double vision, we have to check binocular single vision. And refractive error is difference between the both eye is more than 3 diopter. Also, we have to check binocular single vision before prescribing glasses. This is the patient's flow in our vision center. When patient entering the vision center, first registration, then vision and refraction. After that, slit lamp biomicroscopy, then dilate fundus examination, taking fundus photograph, teleconsultation with the doctor, following by the doctor advice, counselings are done by counseling system. So the conclusion is, after a comprehensive eye examination, consider the result of examination to determine a diagnosis. Sometimes more investigation may be needed to confirm or rule out the suspected diagnosis and to develop the treatment plan. Make appropriate referrals if need specialist consultation. Gaining of trust is the basic mantra for getting more patients at vision centers. As a vision center staff, we need to know, understand about the local community and competent in clinical examinations, counseling skills to help patient getting treatment like glass advice patients, surgery advice patients. If we are referring the patient to base hospital, we have to explain in details to the patients, building and maintaining the relationship with the community. Thank you.